from afar. But we'll be honored to hear from Dr. Joshua Mammen. He's the professor and chair the Division of Surgical Oncology and Department of Surgery at UNMC. He will be presenting on contemporary treatment for retroperitoneal sarcomas. Thank you.
Well, thank you, Dr. Minion. Really looking forward to our doing this presentation, as well as the discussion that will follow with the panel afterwards. So, in terms of disclosures, I have no relevant financial disclosures, but perhaps the most important disclosure, which you may have gathered from the introduction, is that I am not a radiation oncologist, and certainly do not have the degree of expertise that most of you do in terms of understanding tangents and radiation fields and kind of those type of technical details, particularly that have discussed over the last day and a half. I'll provide a little bit more of an overview of sarcomas in terms of their treatment, sarcomas of the retroperitoneum specifically, as well as discuss a couple of trials, one that's already been completed and that we have the results of that's relevant for STRAS-1, and then STRAS-2, which is currently accruing. So again, just a little bit in terms of a guide for our time together today. First, I'm going to start off with how we do an initial evaluation of retroperitoneal sarcomas, a couple of examples of cases to provide us some context on the challenges for resection, a little bit of a background on role of radiation therapy, the role of neoadjuvant chemotherapy. Then at the end, we'll actually talk about recurrences and perhaps how they can be handled. A little bit about the evaluation of retroperitoneal masses in general, and fundamentally it's a radiographic evaluation. And really there are two goals typically when we evaluate masses in the retroperitoneum. One is to try to establish a diagnosis. And often, in fact, the diagnosis can be established from imaging characteristics, which is a little bit different than many other malignancies in which we're often saying that we have of tissue being the issue. Sometimes we won't be able to have an accurate tissue diagnosis for retroperitoneal masses. And the second characteristic or goal of imaging would be able to determine the resectability of the mass. Really kind of the gold standard or the typical imaging modality that's used in terms of cross-sectional imaging for retroperitoneal masses and sarcomas in particular is CT scans. They're useful both for staging, so CT scans of the chest, but also for evaluation of sarcomas of the chest, abdomen, and pelvis. And really what's critical in these imaging studies is really to be able to identify what are the key anatomical relationships that determine resectability. And particularly that's relationships with neural structures as well as with vascular structures. And in the retroperitoneum in particular, really knowing the relationship with the vena cava, is there involvement or invasion, the portal vein, as well as the aorta is really critical to be able to understand. There may perhaps be a role as well for MRI, particularly when we're trying to really discern resectability. If there's a question, particularly if, going into the neural foramina of the spine, sometimes an MRI can be quite helpful in being able to delineate those characteristics. So really it's a question of resectability. An MRI can add a little bit more, but it's not typically used as the major study. And then for certain pathologies, particularly malignant peripheral nerve sheath tumors, a PET CT scan can sometimes be helpful in being able to understand a little bit more about the lesion. I alluded to biopsy just a moment ago, and biopsy can be helpful, particularly for non-lipomatous masses. And really it's image-guided biopsy. It's directed towards a more solid area of the lesion, and we'll see some radiographs in a moment and be able to discern the difference between what may be more fatty versus more solid areas. Generally need CT guidance for these retroperitoneal lesions. Sometimes you can do it with ultrasound. I have seen in the literature them mentioning doing it almost blindly by palpating the mass from the outside. I don't recommend that because often there's necrosis or other areas that are not really particularly helpful from a diagnostic perspective. So really imaging guidance is, I would say, essential to being able to biopsy these masses. And really CT scan is the standard of care. In general, you want to try to avoid crossing tissue planes. You sometimes can do it endoscopically, actually, so not CT guided, but endoscopically, particularly if it's near the rectum or near the duodenum, and that way you can avoid contamination to the outside. Because sarcomas, of course, are one of those malignancies, even with sheets, where there can be contamination from the needle itself. And incisional biopsies or open biopsies really should be rare. And finally, and alluded to this earlier, perhaps a biopsy is not necessary. If you have a large mass like some of the masses that we're going to see, frankly, they need to be resected, and a biopsy really won't add a whole lot more to the management or the sequencing of management. I'm just going to provide a couple examples really to just provide some context to our discussion. Many of you have seen these type of cases before. And this is case one of a retroperitoneal sarcoma. You certainly see this large lipomatous mass. And as these retroperitoneal liposarcomas tend to do, you can see that shifting the bowel to the right side of the abdomen. The kidney happens to be, in this case, relatively in situ. And you can see that the entire remainder of the abdomen is filled with this mass. You can actually see a portion of the colon. This is transverse and left colon right in the middle of this mass. What I would say is particularly relevant here is the typical 1 centimeter margin that you would like for truncal or extremity sarcomas is not possible in a situation like this, because you can clearly see that there's bowel, there are critical central vasculature, this kidney that you may want to save, and certainly the abdominal wall. So, and this 1 centimeter margin is not a real possibility here. Additionally, in terms of radiation, you can certainly imagine this is a large area that would need to be radiated. Additionally, there's significant issues with bowel toxicity and perhaps renal toxicity trying to radiate this entire area. This is the mass in situ. You can see it's quite large. And this is a couple of pictures of resection. What I would really like to highlight here, you can see the kind of the glistening surface of the mass, showing that the capsule itself is intact, and which is, even though you can't obtain a 1 centimeter margin, you certainly try to remove this as a completely intact mass. And just another radiograph, another picture on the back table. Now this is another mass. This is a slightly different. This is again a liposarcoma. You can see in this case, the kidney itself is actually lifted up from the retroperitoneum, but still remaining retroperitoneal, but right almost to the center of the abdomen. You can see once again the colon that's lifted up. This is the left colon. This is the mass itself. And again, you can kind of clearly see that a 1 centimeter margin is not possible in this situation. And then trying to radiate this large area that's at risk for microscopic involvement is just not easily feasible. It is a significant challenge, though certainly tempting, because that's where we know the recurrences are very likely. Again, this is a mass removed and completely intact, which is the goal. Glistening surface, which we'd like to see. This is another couple of pictures. With regards to the issue of radiation therapy, certainly something that as surgeons we certainly would very much like to add to the armamentarium and the treatment of these lesions, because we know how likely they are to recur. The rationale, of course, is local control, just like surgery is, and we may perhaps also allow for a more conservative approach. And we certainly have found this to be true with regards to sarcomas of the extremities and truncal sarcomas. What's the benefit of preoperative radiation? And I'm preaching to the crowd here. Certainly at smaller fields of radiation doses, you don't delay treatment, so you don't have to worry about the time required for surgical healing. Perhaps you can limit tumor dissemination during surgery by creating a nice rind or capsule like we see for sarcomas of the extremity or truncal sarcomas. And that certainly goes with capsule thickness, making the surgery actually easier sometimes for the surgeon, where you have that nice capsule where you can actually just lift the mass off of surrounding structures. And certainly in a benefit which we certainly are in favor of, which is allowing multidisciplinary cooperation early on in the patient's management. In terms of post-operative radiation, the potential advantages is that then you can base radiation upon the surgical results, perhaps if the margins are positive, and sometimes we do that in sarcomas of the extremity, where we think we're going to resect with a negative margin, but it comes back actually with microscopic involvement. I mean, perhaps if it's a higher grade than we accepted, or there's subtypes, so maybe avoid radiation in individuals that may not have potentially benefited by being able to tailor it. But of course, a major downside of postoperative radiation is you can imagine that after that mass is removed in either of those pictures, you can imagine that the bowel or other structures may fall into the field of radiation treatment and limit the ability to provide doses of radiation to be as therapeutically beneficial as you would like to aim for. Certainly, that's a question that's long been asked, and certainly this trial was one that was meant to try to answer this question. This is a STRAS-1 trial. And again, as we all know, unlike other areas in terms of sarcomas and radiation, really the efficacy of treatment with radiation for retroperitoneal sarcoma not and has not been well established. This was not the first trial to try to establish that. There's certainly been retrospective studies that have looked at that. And in fact, in the United States, the ACOSOG Z9031 study was an attempt here to randomize individuals to 2 arms, radiation versus no radiation, as an attempt to answer that question. Unfortunately, because individuals have strong opinions, like do, that trial was not able to accrue. In fact, that trial, after opening as a cooperative group trial, accrued less than 20 patients, and it had to be prematurely closed due to lack of accrual. So certainly, we've tried to answer this question, but we failed. But this European trial was able to get further along. And as you can see, there with inclusion criteria, they had to be resectable or thought to be resectable, and they also had to be able to get radiation. The radiation dosage was 50.5 gray, divided into 28 fractions. And the 2 arms here, as you can see here, is surgery with a maximum of 4 weeks after diagnosis, versus the other arm being radiation for 6 to 7 weeks, and then resection 4 to 8 weeks afterwards. A little bit of details of these patients that accrued on this study. You can see that the aim was a total of 266 patients actually did accrue. There were at 31 centers. Median follow-up for this trial was 43.1 months. And you can see that they're pretty evenly matched patients. But I would like to point out a couple of things that I think are relevant as we try to cross-apply this study. About 40% of patients with retroperitoneal sarcomas are liposarcomas. You can see in this trial, about 75% of individuals who were accrued in this trial were liposarcomas. And again, at approximately 25% of individuals with retroperitoneal sarcomas are leiomyosarcomas. This is a slightly lower proportion of leiomyosarcomas in this group. You can see most of these individuals, and this is the kind of how the total subjects ended up being included in the intention to treat analysis. And these are the survival curves, and as you can see, I think it's quite obvious that the survival curves are completely overlapping in both arms. The median recurrence-free survival for the radiation arm was 4.5 years, and for the surgery-only arm was 5 years, so completely overlap. So this ended up being a negative trial. In terms of events, there were certainly higher events in the neoadjuvant radiation arm, with 77% having lymphopenia versus 1% in the surgery-only arm, 12% having anemia versus 8% in the surgery-only arm. But all's not lost. Perhaps there's a little bit that we can glean from this study, and in fact, it has to do with the liposarcoma subgroup. And the authors fully acknowledge that this is completely exploratory, that they can't make any definitive conclusions from the subset analysis, because this is a post hoc subset analysis. But in terms of abdominal recurrence-free survival, there was a difference that there was a suggestion of a difference adequately powered between the 2 arms, with the abdominal recurrence-free survival at 3 years being 65% in the surgery arm, but being 75.7% in the neoadjuvant radiation arm. Again, a difference of about 10% between the preoperative radiation versus surgery alone. Again, completely exploratory, not adequately powered, and certainly we couldn't make any definitive. Well, and certainly having explored the issue with regards to neoadjuvant radiation, the issue also has been raised is there a subset of individuals in which neoadjuvant chemotherapy might be beneficial? Well, what would be the benefits of neoadjuvant chemotherapy? Very similar to an approach from neoadjuvant radiation. There would be no delay in treatment, again, to allow for surgical healing, early multidisciplinary cooperation, perhaps decrease the extent of surgical resection. But perhaps what we all kind of look at in a neoadjuvant space with chemotherapeutic regimens is perhaps it will provide us an understanding of biology and the effectiveness of systemic regimens, which may allow us to better discuss a patient's prognosis with regards to their ultimate outcomes. And certainly what we hope for is an improved disease-free and overall survival, though that would be an open question. But even understanding the biology would be a huge benefit for us in being able to help guide our patients. For the reason For that reason, this trial was created, which is a STRAS-2 trial. This is an ongoing accruing trial. It is open in Europe and in Canada currently. There are significant efforts right now through the ECOG cooperative group, and SWOG is also interested in opening this trial in the United States, and those negotiations or discussions are ongoing right now. So this trial is slightly different in the sense that the two pathologies that this trial is open for are high-grade liposarcomas and leiomyosarcomas. So the two histologic types that would be most likely to be sensitive to systemic chemotherapy. And again, it's very similar in the sense that it has two very simple arms. One is surgery up front, the other is preoperative or neoadjuvant chemotherapy followed by surgery. The inclusion criteria are very similar in the sense that they have to be candidates for chemotherapy, as well as be thought to be resectable sarcomas. Very similar to STRAS-1. Secondary outcomes are overall survival, local recurrence-free survival, recurrence-free survival, and distant metastasis-free survival.
Dr. Mammen, can I pause you for just one moment?
Of course.
You skipped just a slide ago. Could you just repeat what you said on that last slide?
I'm so sorry. It must have cut out then.
That's okay.
So 250 subjects. The primary outcome here is disease-free survival. And very similar again to the STRAS-1 trial. And the secondary outcomes here are overall survival, local recurrence-free survival, and distant metastases-free survival. And please interrupt me if anything cuts out. Thank you. Final area I want to touch on is recurrent disease. This is really one of our challenges, and frankly, there are no trials, I would say, are adequately powered or had an adequate number of patients to be able to really understand this issue. So really what we have are consensus statements, and this is probably the best consensus statement. And this is from the Trans-Atlantic Australasian Retroperitoneal Sarcoma Working Group, which is a really robust working group that we have to really think about retroperitoneal sarcomas and how to best treat them. And we actually incorporate a lot of the things that we do for retroperitoneal sarcomas in other areas that we've actually been able to do trials in, and try to incorporate them in some fashion in the retroperitoneal, in the recurrent space. And really, it's again, very low level evidence at this point, but we consider cytotoxic chemotherapy. We consider preoperative radiation, particularly if it hasn't been previously administered. But again, it's a very slow or very minor recommendation, since we know we don't have good data. And we know that responses vary between histologic subtypes, so we take that into account as well. The resection is, we acknowledge, of course, the technical challenges of doing an en-bloc resection. The planes are no longer there. The anatomic relationships are completely distorted. And vascular involvement may be present now. Often when we save the kidney in one situation, the kidney is involved in the situation when it's a recurrence. So that certainly needs to be considered. We really don't recommend using frozen section, which is often helpful in other malignancies because it's so inaccurate in this setting. And there's a large part to this document, which I did not include for the sake of time, on the preoperative assessment prior to resection, which includes reviewing all of the previous operative notes to understand how the resections were done, particularly if they were done at a different institution, as well as reviewing the pathology from the previous resections as well as understanding the trajectory of recurrence. Because if the recurrences are becoming more and more frequent, then in a sense, you're fighting a battle that you can't win because the recurrences happen so quickly that really questions the benefit of the surgical resection balanced with the morbidity. And finally, in terms of postoperative therapy, again, no proven role for prophylactic systemic therapy, meaning that there's no role if you've been able to do a complete resection to just give adjuvant therapy, the hopes of preventing a recurrence. And as well, there's quite no role for intraperitoneal chemotherapy, which we use for other malignancies, though you can certainly consider on a clinical trial. So it really is a very challenging situation. One benefit or one strategy you can provide to your patients to help to understand this disease better is this app. This is a free app, so this is not, I have no stake in it, and this is certainly free, but certainly something that you may want to consider downloading on your phone when you have these discussions with your patients. The Circulator app is readily available. And even for initial sarcoma, retroperitoneal sarcoma diagnoses, as well as the recurrent setting, this app can really provide some context to patients because it provides in a very granular fashion based on the available data, the likelihood of recurrence of these retroperitoneal sarcomas based on histology, the individual's age, size of the mass, etc. In summary, we can see that cross-sectional imaging is typically with CT scan, though there may be some role for MRI or PET scan. Percutaneous biopsy in many individuals, but frankly, it's not mandatory because often you can make the diagnosis, particularly in those two images that we saw. There was really no reason to biopsy either of those masses because you knew that both of those patients need to undergo resection. The role of neoadjuvant therapy still requires some further definition, as we discussed earlier, and recurrent sarcomas are a challenge. There are some guidelines available, but there's little in the way of trials. Thank you again for the opportunity to discuss this topic, and I look forward to the panel discussion soon.
Dr. Mammen, thank you. A wonderful presentation. Look forward to